Okay, thank you, Chip Allen, for that information. And I think that it is very appropriate for us to designate you the actual health equity superhero of the day. So thank you very much. And according to the program, we are slated for a break. However, for us to get back on track, I would ask that you take a break as you need it, but we're going to continue with the program. So I would like to introduce our next presenter. No, they need to know who you are. So we have Ruqaiijah Yearby coming up to the stage. She is the David L. Brennan Chaired Professor and Associate Dean of Institutional Diversity and Inclusiveness at Case Western Reserve University School of Law. She is also the principal of Indu Consulting, LLC, which seeks to support community organizations, healthcare institutions, healthcare providers, and governmental actors. So with that, I present to you Ruqaiijah Yearby.
Thank you so much. I want to thank so many people, but because of my time, I'm going to be quick. And my thank yous, I want to thank Francis Mills, the Symposium Planning Committee. And I'm excited today because the purpose of my talk is to begin really getting you to think about adopting and developing an equity framework. Before I go there, though, I'm going to talk about the things that we need to do to be able to create that framework and the history that we have to overcome. So when we create this equity framework, we must understand that it has to foster excellence where everyone is valued and respected and supported in their growth and held accountable for behaviors and acts that undermine equity, equality, and excellence. For they all go together and they cannot be separated. We cannot do this work effectively without believing that everyone is a human being and should be valued and respected. For if we continue to celebrate the mediocre and do not work together, we will continue to have health disparities in Cleveland, in this county, in this state, in this country. As Martin Luther King Jr. said, whatever affects one directly affects all indirectly. So we must commit to transforming ourselves, to transforming our employers and our organizations into champions of equity. We must create systems in equity, but we must understand the history of inequality and the injustices that are an integral part of our current systems. I have been asked today to focus on racial and ethnic disparities because those are the most studied, but I will also take time to focus on gender and equities. So this is a quick roadmap of what I'm going to be talking about today. So equality versus equity. We have never achieved equality nor equity in the United States because of the continuation of discrimination. It has affected our laws, our housing policies, education, our economy, and healthcare. And although we seem to believe that these systems are neutral in some way, they are simply instruments of human behavior. So when we take a look at the history of inequality, you can see that it has been a long time in the United States. In fact, only for 20 years out of the 399 years that I'm accounting for on this slide has the government actively tried to equalize and treat people as human beings. For 379 years out of 399, racial and ethnic minorities were building this country through their physical efforts and their tax payments. And at that time, the government was using the money to subsidize and build a nation which they cannot participate in. I will talk about how this inequality came about through the 3 levels of discrimination and how they impact our health. So as you see, as Chip already mentioned, we focus on different areas. Most times we focus on the interpersonal, which is a direct impact when people say or do things to us at work. But we need to also focus on the institutional policies that may be neutral, that have a disproportionate impact on racial and ethnic minorities. Furthermore, we must address the structures of this country that have been set up to come out with the results that we have of inequality. And let me just give you a brief example. The 400 richest Americans own more wealth than the entire African American population, plus 1/3 of the Hispanic population combined. This wealth was not distributed based on principles of equality. It was based on legacy policies, generational transfers. And what does that mean? That means that when we look at education, as of 2012, students were 3 times more likely to be admitted to Harvard and Stanford if someone in their family went to that school, not because they were smarter, not because they worked harder. Yet, when we look at our federal government today, the challenges that they are making to college admission practices is by focusing on limiting access to racial and ethnic minorities, not getting rid of legacy policies that were adopted in the 1920s and 30s to keep college populations more homogeneous. In fact, in 1922, the chairman of Princeton's admissions committee acknowledged that they wanted to address the Jewish problem, and so they adopted legacy policies that we look at today. I would be remiss if I didn't acknowledge the opinion piece that just came out 5 days ago in the New York Times that showed that colleges recruit and typically visit schools that are predominantly Caucasian and predominantly richer. And yes, that may be a neutral business decision, but again, it has a disproportionate effect on racial and ethnic minorities. And I will say a couple of schools from Cleveland were mentioned. You can go look at the report. I'm going to leave it at that. So when we look at inequalities in wealth, wealth is money in the bank that allows families to buy a home, obtain a college degree, and retire. A 2006 Institute for Policy study noted that over the past 3 decades, the average wealth of Caucasian families has grown by 84%, which is 3 times faster than the rate for African Americans and 1.2 times the growth rate for Hispanic families. But perhaps this can make an even more important impact on you, that if the rate of wealth growth continues at the same rate that it has for the last 30 years, it will take the average Hispanic family 84 years to build the same wealth of a family of Caucasians. That means that the year will be 2100. It will take the average African American family 228 years to build the wealth of a Caucasian family in 2016. That's the year 2244. That's 17 years short of the 245-year span of slavery. We have a lot of work to do. So I'm going to briefly just highlight some of what Chip was discussing in terms of redlining. It was the policies, and it was the creation of the Federal Housing Administration. It refused to insure loans for African Americans, and private lenders followed suit. Thus, in 1950, only about 2.3% of the FHA insured mortgages were outstanding to non-Caucasians, and only 5% were for private loans were for non-Caucasians. By 2016, home ownership for African Americans had risen to 41%, 45% for Hispanics, and 71% for Caucasians. But that doesn't mean anything if you are charged more for your loans. That doesn't mean anything if you are pushed into subprime loans, and that's exactly what Countrywide and Wells Fargo did, which led, when we had the mortgage crisis, which led to many African Americans and Hispanics losing their housing. Has that changed? No. But in 2018, Congress passed legislation that cancels the requirement of credit unions, mid-size and small banks to report racial data relating to home mortgages, even though a 2008 report showed that redlining persists in 61 metropolitan areas, including my hometown, Detroit. And as you know on the slide, the housing department, led by Ben Carson, is actually thinking about removing from its mission statement that they will focus on racial discrimination. So what does this mean in its impact on health? A result of discriminatory housing law and practices, which continue today, many neighborhoods are racially hyper-segregated and usually have less economic investment, more stressors. In fact, research shows that the presence of one or more health clubs, as well as lower crime rates, was directly associated with lower cardiovascular disease in African American women. This is true in Cleveland, and I'm not going to go through it because Chip did a fabulous job going through the impact of it. But let me move on to inequalities in income. Studies have shown that there are inequalities in income for Hispanics and African American families. A study in New York found that Mexican immigrant fathers earned $8 to $10 per hour compared to $10 to $15 an hour earned by non-Mexican ethnic minorities, and tended to work on average 54.5 hours a week compared to 40.2. And in Arizona, after the passage of the Legal Workers Act, Hispanic immigrants employees received empty paychecks or were required to work more hours for the same pay. And again, that's happening today. When we look at income, it's defined as money necessary to meet daily expenses and usually derived from pay. Black women have to work 7 months until 2017, and Hispanic women have to work 10 months in 2017 to be paid the same as Caucasian men in 2016. And if you think it gets better as women move up the ladder, let me tell you, African American women physicians and surgeons make 52 cents for every dollar that a Caucasian male physician or surgeon makes. So when we see the gaps, I want to highlight some, and particularly as Hispanic women increase their educational attainment, their pay gap with Caucasian men increases. The largest pay gap is $17 an hour for workers with more than a college degree. And African American women with some college get paid only 42 cents more than a Caucasian man without a high school degree. Married African American women work 200 more hours per year, 2 more weeks per year, 3 more hours per week, and make $3 less per hour than married Caucasian women. So least you think that it's just based on race, gender is also an issue. When we look at inequalities in employment, the unemployment for African Americans has been at least twice as high as Caucasian unemployment for all but 7 years during the 53-year period between 1962 and 2015. But why is this the case? Why? Because discrimination and hiring persist. It persists through neutral policies as well as through clearly discriminatory practices. So when we look at the neutral policies, you see that institutions continue to hire using referral policies. And that's great if we all interacted with each other, but we don't. And so the people who are traditionally referring people are the people who have the jobs, which tend to be Caucasians because African Americans are unemployed. And who do they refer? Other Caucasians. Research has shown Caucasian women were 12% less likely to receive a referral. Men of color were 26% less likely, and women of color were 35% less likely. You don't get a referral, you don't get the job. Even if the job is posted, we've seen studies that found African Americans with non-Caucasian names receive 50% less callbacks than African Americans with Caucasian sounding names, even if the resumes were the same. But if you whiten your resume, if you change your name, you have an increased risk of getting a call back. Perhaps not the job, because a 2009 field study conducted in New York found that when you show up, oftentimes you're excluded, there's shifting standards, and they shift you to a lower job if you're African American. Getting a job is not all. Once you get the job, do they feel like or treat you like you deserve to be there? 42% of women have been discriminated against at work, say that they have. 40% for Hispanic and Caucasian women reported experiencing discrimination at work. 53% of African American women reported experiencing discrimination. 57% of women who reported experiencing discrimination had a postgraduate degree. So you work so hard to get the degree and still you're discriminated against. You'll see in the slide, it notes that of the women experiencing discrimination, 25% said they earn less than men doing the same job. 23% that they said they were treated as if they were not competent. 7% say they were denied a promotion or turned down for a job. So how does this impact health? We see discrimination in employment and income, and it affects our health status and our access to health care, and let me tell you how. We see African American women who experienced racism and had chosen not to object were 4.4 times more likely to have hypertension. We see that research has shown that experiencing racism accelerates the biological aging of African American men, which may lead to their lower life expectancy. And part of the study was not just about them experiencing it, but them internalizing it, actually believing that they were less than, which lowered their life expectancy. Now, experiencing racism also leads to unhealthy behaviors. This was a study that was published in 2010, which reported self-reported experiences of general racism. 56% of African Americans reported experiencing general racism, 30% for Hispanics, 12% among Caucasians. And this impacts healthy behaviors. The odds of being a current smoker increased by 24% for those who reported experiencing general racism sometimes. And the odds increased by 95% for those who reported experiencing general racism often or all the time compared to those who did not. But let me be clear about those numbers. That was everybody. That was white, Black, Hispanic, Asian, everyone who experiences racism has increased odds of being a smoker. Inequalities in healthcare. As you can see, it costs a lot. Yet we haven't made the changes that we need. A 2017 study using records from 2006 to 2013 found that African American and Hispanic patients suffering from neurological ailments like stroke, Alzheimer, and Parkinson's are likely to receive significantly less or different care than Caucasian patients. The study found that Hispanic patients were 40% less likely to see a neurologist for their condition compared to Caucasians, and African Americans were nearly 30% less likely, even though they had similar resources and education than the Caucasian patients. I'm sure you're aware of these studies, so I'm going to go through them a little quickly in terms of interpersonal bias. But the first study was done in 1999, showing that healthcare providers do have bias against African American patients. And let's be clear, the research has shown that that's the case regardless of the race or ethnicity of the healthcare provider. In fact, I held a conference and Dr. Van Ryan came to speak and said that the African American students, that their anti-African American bias increased as they went through medical school. So obviously we're doing something wrong. But I want to highlight the 2000 and 2006 study that Dr. Van Ryan did, which shows that physicians rated African American patients as less intelligent, less educated, or more likely to fail to comply with physician medical advice even when individual evidence contradicted the physician's prejudicial beliefs. Physicians acted upon these beliefs by recommending medically necessary coronary bypass surgery for African American males less often compared to Caucasians. Even though we have civil rights laws in place, they do not apply to healthcare providers. Let me say that again. Even though we have anti-discrimination laws in place that prohibit racial discrimination, Title VI of the Civil Rights Act, the federal government does not apply them to healthcare providers. So there has been no change in these perceptions and these actions, and the ACA did not change it. I think we're kind of clear on the impact interpersonal bias has on health, so I'm going to skip this slide. I'm just trying to keep us on time. Okay. And I am going to skip going into a lot of detail because I want to talk about equity framework. But if we are going to end structural racism, I'm a lawyer. Part of the problem is we don't enforce the laws that are on the books. We don't. And we're rolling back those laws every day. So one of the things that we need to do is be clear about enforcing the laws. But I want to move to at least the exciting part for me in the presentation about adopting an equity framework. To do this work, we must have the courage and integrity to create conditions of equality for all people. So as Chip said, when people tell us no, when people close the door, we need to walk around or go someplace else. As individuals, we must examine our own beliefs and practices and make changes to counteract the contemporary and historic impacts of discrimination. Healthcare institutions and all institutions must make structural changes to their policies, their programs, and services. And what do I mean by this? I'm going to talk about 4 particular things that we need to do. First, we need some equitable leadership. That means we need to nurture, that we need to provide support for people to thrive and excel in the workplace and surrounding community. Leadership should be based on values of honesty, integrity, and fairness, as well as accountability. Allow for review of the employees and the leaders by the employees in the community. Support, reward, and hold each accountable for outcomes. We must honor our employees and the community members for their skills and their contributions. We must establish transparency about our mission, our goals, job duties, and responsibilities. And I'm going to repeat this several times. If it is not part of a person's job, do not add it without increasing their pay. We need to pay people for the things that they do and their worth. Just because you can get away with paying them less is not going to lead to the outcomes that we need. Pay people what they are worth. We need to champion true merit, not symbols of excellence, like where the person went to school. Merit is about what the person can do, achieve, and what they bring to the job. When we think about recruitment and retention, we need to minimize referrals. Do not allow for shifting standards and preferences, not connecting to job duties and responsibilities. And I can tell you I deal with this all the time. As Associate Dean, my role on the hiring committees is to ensure that what we write is what we mean. And every time somebody starts talking about things that are not on there, then it's not important. If you didn't put it on the job posting, it's not important. I don't care if the person has a PhD. If they can't answer the question, I don't need the PhD. I need the person to do the work. Be willing to hire non-traditional candidates because they provide different skills that support the team. If somebody has been unemployed for a long time, bring them in. They might have different skills of professionalism, understanding that you need and that will support your team. When we talk about promotion, you need to connect members of the staff with sponsors who will help them move up in the company, not mentors, sponsors, people who will open the door for them in that job. I can tell you in my first job working during law school, I had a sponsor. He walked door to door throughout the law firm to tell people who I was. So when I talked to other people, they said, "Oh yeah, we know about you." Right? You need a sponsor, and that needs to be part of the company's development. You need to hold career development and training sessions during the normal course of business. Do not require people to do it over their lunchtime. Do not require people to come in early. When you support people, they do the hard work. You should have employees draft yearly career plans that include goals for obtaining new skills and proficiencies. Have managers draft yearly plans that include goals for supporting and promoting their staff. And again, I told you I was going to say this a couple of times. Pay people what they are worth, not what you can get away with. During the normal course of business, provide time for activities related to stress management and community building, such as negotiation, mediation, walking, and yoga, such as monthly breakfasts. I can tell you this has been a struggle at my own institution. They always want us to do it at lunchtime. That's not community building. That's me giving up something, right? You build it into the day because a happy, supportive employee group gives you back tenfold. Let's talk about corporate responsibility. You need to support the businesses that are in the communities. One example would be to allow beauty shops and barbershops to be housed in healthcare facilities. If you support the community, make it a part of your business plan. Allow them to have space at your business because it brings more people in, they start to feel comfortable. Use products made under fair trade. There are lots of products that are made by prisoners. I'm not going to tell you the companies because then we can't shop. But hear what I say. There's lots of companies that get things from prisoners. We don't need to support them. Finally, stop punishing people for asking for fair and equal wages. It is their right, and you need to reward them for that. Build wealth in minority communities. Provide savings accounts for children to provide support for college and other career opportunities. Provide down payment accounts to purchase houses, and provide retirement accounts for low-wage workers. Many hospitals are reinvesting in urban communities, leading to gentrification, but that also means that gentrification usually means moving people out. That's not what we need to do. What we need to do is provide the money to the people there to develop their businesses, to develop a business plan, and to be able to stay in the places where they already are. Finally, I want to go to something that Chip mentioned, right? That hospitals have community needs benefit health assessments. It needs to be community-driven, not driven by the people in the hospital. You need to conduct an equity assessment in collaboration with the community. The community should be involved in all levels. When you sit down to say we are going to start this process, you need to have them at the table. And what I mean by community is that you need people who live there, not just people who run the organizations that are there. You need actual residents. They need to be making the decisions, planning, developing, and delivering the healthcare systems. The community should also provide the idea for design and funding to implement the interventions. This means, and this goes back again to employment, this means when you ask a community health worker, when you ask people from the community to participate, that you pay them. They don't need to volunteer. Right? I don't see CEOs making $49 million a year volunteering anything. The people at the bottom do not need to volunteer. You need to pay them for the work that they are doing. And so part of your community assessment needs to be how you are going to pay them, how you are going to support them. And guess what? Give them some health insurance too. Because it makes no sense that we have workers in the hospital providing health services, home health aides, that we have people working in this healthcare system who cannot live and don't have health insurance themselves. So I want to move now to a case study and talk about how even though we might have the best intentions when we're thinking about health, they sometimes have an unintended consequence. So I know many of you have heard smoking bans for employment. We are thinking about imposing one at Case Western Reserve as well. It may be a neutral policy, but it has a disproportionate impact on racial and ethnic minorities as well as the poor. Smoking rates in 2015 among Ohioans were highest for Hispanics, 29%, African Americans, 28%, those who had less than a high school education, 43%, and those who had an annual income under $25,000, 35%. Dr. Monica Webb Hopper of Case found that African Americans are least likely to be prescribed 8 to 12 weeks of nicotine replacement medication or to have more than one session of counseling. And remember what I said, the odds of being a current smoker increase by 24% if you report experiencing general racism sometimes, but increase by 95% if you experience general racism often or all the time. Treatment programs do not teach coping mechanisms to deal with experiencing racism. We need to do that. And let me be clear, I'm not reading too much off my slides, but I want to highlight the fact that one of the anti-smoking drugs has been associated with increased risk of heart attacks and strokes. So when we think about implementing the smoking bans, let's be clear about who we are impacting. We are impacting the poor. We are impacting racial and ethnic minorities. They smoke because they're stressed, because they go to work and they're discriminated against, or they don't get paid, or they don't have health insurance. And then what do? You fire them so they smoke some more. That's not the outcome that we are trying to get to. So I want to conclude with this from Dr. Martin Luther King, and the same as Chip Allen did. We must work together. We must learn to live together, to work together as brothers and sisters, or we will perish together as fools. And if you look at our current system, we are going down the road of perishing together as fools. We need to work together to address the structural issues, the neutral institutional policies, the ones that are not. We need to address interpersonal racism. We do it by our actions, by every day in the things that we do. If we really respect and value people, then we treat you accordingly and we support you in your development because we all benefit from that. So with that, I'd like to thank you.
So if once again you could write your questions on your note cards that are posed at each table, and then we will ask those questions of Ruqaiijah Yearby. The first question is, how do you introduce sponsors within the culture of your company? How do you get the buy-in?
I think the way you get the buy-in is to talk about how it will make your company better, how you can support the people to make your company better. Sometimes it doesn't work, right? And that lets you know where you are in the institution and perhaps you need to move to another one, right? I'm just being honest, right? And so let me say this. I am moving to St. Louis University. Let me leave it at that.
Moving on to question number 2. What programs and resources are available to young Black women and men leaving college and entering the workforce that demonstrates ways to navigate all that you described, for example, negotiating salaries?
So I would say there are lots of tools out there on the internet that you can look at. But I want to sort of move back a little bit into something that I didn't include in my presentation that I think is so important is you have to have a plan, right? And so as Chip said, you don't wait for somebody to save you. I didn't wait for a case to develop the associate dean position. I developed it myself. You have to help yourself. And so if you are in college, you should have a plan about where you want to go. You should already begin to reach out with some of the people who are here, with some of the people who are in the community, because they've already done it. So part of it is have a plan. Reach out to people. Ask them about what they did and what are some of the things that could help you.
Okay, these questions are getting heavy. I'm just preparing you.
Okay.
So there's a local organization that is imposing a smoking ban beginning sometime in July of this year. How can the community provide support to them during this time, specifically residents, as they will be greatly impacted?
So I would say part of it is going to the institution to make them aware of the effects that it is going to have. Because we often tout things as if it's great and we don't understand the impact that it has. So I would say that is one of them. 2, we need to also educate them about the resources that our people are getting, right? And so when you say that we are doing a smoking ban, you're assuming that people are getting something to support them that will actually support them in not smoking, and that is not the case, right? 3, we really need to focus on supporting people in terms of experiencing racism, right? It's not just you're going to stop smoking just because we give you a patch. The stress is still there. So we need to support people in our communities of dealing with stress, of talking it out. And so maybe they don't go smoke. Maybe they come in and we can talk about it and we feel better about ourselves, and then we don't smoke.
Okay. Are you ready? How do we motivate those who directly benefit from systemic racism to change?
So my husband is quite thoughtful. And so one of the things that he noted was that, and I've said it more than once, but I'm gonna keep saying it, we no longer support them, we no longer work there, right? Part of the issue, as Chip mentioned, is that we don't use our voice and our power to get people to change. And so if there are institutions that claim they are doing this work and they're not, we need to be quite vocal about it. And I can tell you, I'm very vocal about it at my school. Every time they come out with a policy or something comes out, like they came out and it showed that they weren't going to predominantly minority schools, and that came out 3 days ago, I made sure to email everybody about that. And then when they said, no, we're doing work, I kept emailing them and saying, no, you're not. Let me tell you what you're doing. Let me tell you what you need to be doing, right? So because I have that power and that voice, I let them know at every opportunity what they are not doing right. But I also provide solutions to them. So it can't just be me, though. Right? It has to be all of us. And so when somebody gets up and says something, we have to be vocal and support that person as well. It can't be the same person, and we need different ways to do it. We need to call our legislatures. Maybe we need to get on and say, we're not going to support these organizations for the things that we're doing. And yes, they may penalize us as they have done, right? And I read a state was penalizing a city for taking down the statue of the KKK person. They penalize them, but then we need to provide support so that they can continue on in their struggle.
Another question, how do you pay community members willing to participate if the program is grant funded and there's funding limitations?
I don't think we should use grant money. I think part of the issue is that we feel that we should pay people out of grant money. No, we need to institutionalize them. As Chip said, you get a grant, you report it, it goes away, and then you move on. No, you have to institutionalize these projects and these people, because the point is, if you are committed to it, then you put money behind it. And I'm sorry, I know the CEOs of the hospitals, of the institutions, make millions of dollars. They can make millions of dollars less. Take 1% and use that to pay the people that are doing the work. And let's be clear, pay the people who are writing the grants. I hear so many times that the people writing grants are not getting paid. That makes no sense. That makes no sense. If the people are supporting you getting the money, they need to be paid, they need to be full-time employees, and they need benefits.
Okay, last but not least, this is not a question but a statement. I want to thank you for being an advocate and a voice for those who don't seemingly have a voice. And this is a member of the audience.
Thank you. Thank you. I just like to say I'm so blessed to have been here to be able to begin this discussion, and hopefully I motivated you to go out and continue this work. It is not easy. It's a fight. You are not alone. You are valuable. You are respected. You are making a difference, and we need to keep pushing along and not just stop when the doors close in our face and people tell us no and people tell us we're not doing it the right way. We got here for a reason, and we need to continue. Thank you.
Okay, you all have been so very patient. We will break for 15 minutes. Thank you.